and move on to the next presentation, we will have now the Zero Dose Learning Hub presenting the key learnings and recommendations with Heidi here on my side. And we also have Erin Nancy online. Erin Nancy, are you with us?
I see Erin, I see Nancy. Yes, everybody. Hi, good afternoon. Or I think it's still morning. Good morning. And Nancy should
Nancy's
be
there.
Yeah, Nancy's with you.
Yes. Hi, good afternoon, everyone.
Nice to meet you.
And we also have Yahaya after their presentation. So Yahaya, can you also come in?
Yeah. Good
Wonderful.
morning, good afternoon, everyone.
Great. Yeah. So
Thank
we're gonna have the general presentation from the Zero Dose Learning Hub, and then Yahaya is gonna go deep diving on the learnings from the Nigeria Zero Dose Learning Hub project. With that, Heidi, I hand it over to you. Yeah, hand it over literally like that.
Thanks. Hi, and thanks, Gus. Thanks, everybody, for being here. And it's a pleasure to see my colleagues online. Let's see. Okay, we've got it up. Good. So yeah, again, I'm Heidi Reynolds. I'm with Gavi. I lead the Learning Hub initiative. Next slide, please. So you can see also the static pictures of our presenters, at least Nancy, who is the MEL lead for the project at the global level, and then Erin Brookhazen, who's the project director. And we'll also do a better introduction of Professor Yahaya, who's coming up following on the Nigeria Learning Hub. Next slide. I am going to briefly speak about the Learning Hub generally and the design, and then pass it on to our colleagues who will talk more about their findings and recommendations. Next slide, please. Great. So the Learning Hub was designed to be a hub and spoke model, meaning that we had we selected 4 countries to be the hosts of the Learning Hubs in Bangladesh, Mali, Nigeria, and Uganda. And they are comprised of local consortia who lead the projects from their countries. And we also have a global Learning Hub provider consortium who is brought on board to synthesize and communicate the evidence and learnings, as well as to provide some technical assistance to the country Learning Hubs. Next slide, please. This slide shows the timing of the country Learning Hubs relative to the EAF, which is the Equity Accelerator funding mechanism that was designed to specifically support zero dose in the Gavi countries, and then the health system strengthening funding during the different strategic periods. So if you look across the bottom, this shows you the strategic periods and the various priorities. In Gavi 4.0, coverage and equity was already a priority. So even though zero dose wasn't necessarily the main strategic objective here, that equity was very much an emphasis, which meant that a lot of the programming that could be happening through the HSS funding mechanism was targeted to improving the reach of under-immunized children. And so some of those funding lines, which is indicated through the HSS funding line, may have already been addressing some of these issues. The Learning Hubs, which are marked by the stars, mainly came on at the end of 2023, end of 2022, and beginning of 2023. And our global Learning Hub provider had come on a little bit earlier in that time period, but I wanted to emphasize the timing relative to the country implementation. And then the Equity Accelerator Fund has been coming on at different time points. And in some cases like Bangladesh, they're still working on their application. And so what this slide is essentially showing you is how that the Learning Hubs are able to provide some early evidence related to barriers and other situation in the countries to inform some of these funding applications, as well as to inform some of the design of those interventions that might be more zero dose focused. And so that has been an important objective and has been some of the activities undertaken by the Learning Hubs, as well as to be able to establish some baselines in their implementation research, and then hopefully be able to measure some change over time relative to some of the effect, relative to some of the interventions that are being implemented. One of the risks, however, is the end of the strategic period when the the learning hubs are meant to end. But the, equity accelerator funding and other funding is likely to still could be continuing into at least 2027. Next slide, please. So a little bit more about the country learning hub objectives. So they are, they have very similar scopes of work, although the details are very much tailored to what the country has defined as their learning agenda questions and their learning priorities. They all are conducting rapid assessments, improving monitoring, rapid assessments to be able to better understand the barriers in targeted subnational areas. That's a very important sort of aspect of the learning hub. And then implementation research, monitoring activities, and then activities to improve uptake and use of evidence through knowledge translation and advocacy. One of the things that, and the beauty of having Dr. Yahaya here to speak later, is you'll be able to see sort of an example of a portfolio of a scope of work that's being carried out in learning hubs, as well as to have some of his recommendations coming out of their implementation. And then just to underscore, the stakeholders are multiple and really are the users and beneficiaries of the information at the country level, as well as also the global level. Next slide, please. So that brings me to the global level and our colleagues at JSI and the consortium, which I'll introduce in the next slide, but to say that that is part of their objective, and what they'll speak to today is some of the findings that are coming out from the learning hubs, because they're working to synthesize and disseminate that information, as well as to provide some of that technical assistance, as I mentioned earlier. Okay, next slide, please. And then this is, so the Global Learning Consortium is composed of JSI with the Indian Institute for Health Management Research based in Delhi and the Geneva Learning Foundation. And we have Rita here today joining us, which is great, in person. And I just want to say that before I turn it over to Nancy, I wanted to just also acknowledge that the contribution of the learning hubs to the activities today, they comprised about 10% of the abstracts that were submitted, and so are also contributing in that way to the overall evidence base. And I'm very grateful for their contributions and that they were able to also then highlight what's going on in Nigeria. And with that, I will turn it over to Nancy.
Thank you, Heidi. And good afternoon, everyone. Thank you. I'm going to, next slide, please. I'll walk through the emerging learnings and recommendations from the Alliance. And these are based on the work of the 4 country learning hubs, as Heidi mentioned. And we've gone ahead and organized these by the domains in the IRMA framework. So, so starting with the identify domain, one of the initial efforts of the country learning hubs was to carry out a rapid assessment of the zero-dose context in their target areas to characterize and understand barriers to vaccination for caregivers and families of zero-dose children. And findings from the 4 rapid assessments have highlighted how barriers are both context-specific and interlinked, and they are not merely additive, but interact in ways that complicate access for zero-dose children and under-immunized children. And evidence from the Learning Hub assessment align with recent research showing multiple intersecting barriers related to gender, poverty, geographic access, and service experience. So for example, while many caregivers place a high value on immunization, their access is often impeded by a web of factors, including women's decision-making in the household, the financial burden of paying for services or transportation, opportunity costs related to work and household responsibilities, and negative service experiences. Lastly, the findings from the rapid assessments suggest that addressing only one barrier may be insufficient. If the broader context is not taken into account. So some related recommendations for the Alliance then would be to integrate intersectionality mindsets into new or existing planning processes. And REACH interventions should be designed to address multiple barriers simultaneously or in combination with careful consideration of the context, whether it's fragile, urban, rural, etc., conflict. And there's a need also to move beyond service delivery and supply perspectives to to prioritize key demand barriers based on evidence. Next slide, please. The Learning Hub rapid assessments have also underscored the value and the importance of primary qualitative and quantitative data in identifying barriers that may not be evident through desk reviews and secondary data analyses. So while secondary data can inform resource allocation at regional and national levels, primary data collected at subnational levels is important for diagnosing the specific challenges faced by communities, and that is necessary to be able to design effective zero-dose interventions. The Learning Hub experience also shows how formative research, when combined with human-centered design, ensures that interventions are context-specific and grounded in community realities. And for example, in Bangladesh, results from their rapid assessment were instrumental in collaborating with the government to refine and design a package, quite an extensive package of interventions tailored to specific contextual barriers. So in terms of recommendations, it's important to integrate primary data collection into situation analyses in grant applications or as an early activity in grant implementation. And this should be done in combination with the existing recommendations on the use of human-centered design. And a second recommendation is to promote a wider adoption of well-tested tools. For example, the behavioral and social drivers of vaccination, the BEST framework, targeted survey methodologies, and the caregiver journey mapping, just to name a few. Next slide, please. We're also learning about the importance of using a theory of change for guiding implementation research of REACH interventions. And a theory of change provides a comprehensive approach to understanding how supply and demand side interventions contribute to reaching zero dose. And this we're finding is particularly useful when the implementation research is funded for just a subset of multiple interventions, and that is the case, for example, in Mali, or for existing ongoing interventions that neither have a clear start or end date or endpoint, and that's the case in Nigeria and Uganda. So the theory of change definitely contributes and supports the rigor of the implementation research in these cases. And in the case of Mali, for example, the Learning Hub is conducting IR on 2 supply side interventions. And so they have a fairly robust theory of change that clarifies all of the assumptions and considers the demand side factors and other necessary conditions for the intervention to be successful. So in terms of a recommendation, it's important to include more guidance on how to use theories of change for any proposed implementation research in country M&L guidelines. And this helps to clarify the underlying assumptions for the interventions and ensure that the necessary factors are taken into account, and also to ensure that a theory-based evaluation will ensure that the rigor will be there. Next slide, please. So our experience to date also shows the potential of peer learning approaches for connecting frontline providers. So early work with peer learning approaches has demonstrated the effectiveness of using a moderated virtual platform to connect frontline providers working in vaccination service delivery. And this platform facilitates experience sharing and problem solving and has resulted in the development of very insightful case studies. Peer learning sessions can be a valuable resource for providers and enable them to overcome implementation challenges by learning from each other's experiences. So in terms of a recommendation, we recommend that peer learning approaches are used and applied more widely to share practical solutions used by providers to address implementation challenges and to foster collaboration across the different cadres of service providers. And I'll just point you to the bottom of this slide. On the Zero Dose Learning Hub website, you can access the ZDLH Peer Learning Exchange materials. So I just wanted to point that out. Thank you. Next slide, please. So another REACH learning relates to the ability and this is more about the model of the country learning hubs, but it's the ability of the country learning hubs to adapt to delays in the design and disbursement of the Equity Accelerator funding, EAF funding, which is not necessarily uncommon. And so, for example, the Uganda team showcased the learning hub's ability to pivot in response to these funding challenges by adapting their research plans to conduct a study that will inform future scale-up efforts. And they were doing this while waiting for the EAF to be dispersed and to be organized. Specifically, the Uganda team adapted their research plans to include an assessment of UNICEF zero-dose interventions in 2 districts. And findings showed that, interestingly, house-to-house registration was a feasible intervention when undertaken by village health teams, and it was acceptable to caregivers, though it may be insufficient alone to reduce caregiver barriers to vaccination, for example, related to transportation and cost. And results of this assessment are being used to inform plans for scale-up under the EAF. So recommendations include clarifying which interventions need additional evidence to inform scale, and consider the learning hubs can be leveraged for additional studies, such as the one that the Uganda team undertook, studies on how to scale or sustain interventions for better planning and implementation of Gavi grants. Next slide, please. And a final learning in the REACH domain is related to the work carried out by FHI 360, supported by Gavi, which highlighted the value of evidence reviews. The FHI 360 team reviewed primary evidence on pro-equity interventions aimed at reaching zero-dose children and missed communities. And the review identified user incentives as a proven intervention. For example, while surveillance data and women's groups showed promise in addressing immunization gaps. And these findings are useful for guiding future program design and implementation. We also found that the scoping review that they used is a valuable resource that ensures program funding guidelines are evidence-based and consider implementation factors. And this methodology could be replicated to expedite design of methods for future types of evidence reviews. So our recommendation is to prioritize using existing methods, such as this one, for future evidence reviews of intervention effectiveness. And also, more effort is needed to quantify and increase the level of evidence of zero-dose interventions. And I'm going to point you again to the bottom of this slide. You can access the pro-equity, the FHI 360 pro-equity evidence map, which is housed on the Zero-Dose Learning Hub website. Okay, next slide, please. So moving on to the monitor and measure domain. And this is something that comes up often in discussions with our Country Learning Hub partners and other alliance partners. And that is that definitions of zero dose, and I think it's come up already today amongst the discussion, but definitions of zero dose children can vary within countries and across countries and even according to the data source. And these varying definitions of zero-dose children can create confusion in relation to Gavi's operational or official definition. And that leads to potential for inconsistencies and conflicting data at global, national, and even subnational levels. And that leads to challenges in designing and implementing effective interventions and accurately measuring and comparing their impact. So in terms of recommendations, we recommend that the Alliance should develop specific guidelines or guidance on operational definitions for zero-dose and under-immunized children to ensure consistent reporting and data comparability. And there's also a need to clearly distinguish between interventions designed to prevent zero-dose, so aimed at reaching children with timely immunization, from those intended to catch up children. And another point out is for additional discussion on definitions and measuring indicators through, for example, targeted surveys, point you to, again, the bottom of this slide. Please see the paper that Gus led and which was published, I think it was last year, the end of last year. And that is also available on the ZDLH website. And there's a very interesting discussion in that paper about data and indicators. Next slide, please. So the learning hubs are using several different monitoring approaches. And that is one of their main objectives, is to improve monitoring at the local level. They're using several different monitoring approaches to obtain reliable data on levels of zero-dose children and other important indicators. All country learning hubs are using targeted surveys such as baseline and endline assessments, with the exception of Mali. They're using just baseline. And this is to gather more accurate coverage data of DTP1, for example, in specific zero-dose contexts. So in Bangladesh, they're also using annual analyses of DHIS2 data, which has revealed significant shifts in the zero-dose and under-immunized landscape. And this, for example, the data indicates that different upazillas were identified as having high zero-dose or under-immunized populations compared to 2023 compared to 2022. And these findings actually challenge previous assumptions about the causes of zero-dose and under-immunization, and suggest that vaccine supply issues actually may be as critical as the difficulties in reaching remote areas. So that's Bangladesh and some of their additional monitoring activities that they're undertaking. And in Nigeria, and we'll hear more about this, I think, hopefully from Dr. Yahaya. In Nigeria, they have developed a very interesting decentralized immunization monitoring approach, DIM, using LQAS, which is being used to monitor both coverage at the LGA level and also performance at the ward level, and which provides really important insights into barriers for adaptive learning and for corrective action at the lowest levels. And lastly, in Mali, ongoing triangulation efforts with multiple data sources such as HERAMS and DHS and SARA surveys, along with a planned LQAS survey, are contributing to a more comprehensive understanding of the immunization landscape. And so our two recommendations in this domain are to use or to consider using the Learning Hub model as a sentinel site for higher quality data and more actionable insights on zero-dose efforts. So this approach allows the collection of higher quality data on select number of small areas or zero-dose contexts, and therefore provides more accurate and actionable insights, while efforts to improve DHIS2 data quality continue. And we also recommend enhancing timely and reliable zero-dose monitoring using multiple methods, such as the ones we've mentioned, which include LQAS and data triangulation, as these are proving to be very useful at the country level. Next slide, please. So limitations in data systems to track changes in key indicators is another important learning in the monitor and measure domain. We are finding, so learning hubs are using DHIS2 data in combination with other activities to enhance monitoring of immunization efforts, but these are or have been limited in some cases by the EAF implementation delays, so specifically in Mali and Uganda, and also the absence of an EAF in Nigeria and Bangladesh. And so while this isn't a specific objective of the learning hubs, it does mean that learning hubs have not been able to monitor changes in key immunization indicators relative to EAF-funded implementation. But despite these challenges, the ongoing analyses using the JRF and DHIS2 data are expected to reveal important DPT trends as EAF implementation gains momentum. Nevertheless, these analyses do face important limitations, including concerns with data quality and a need for better tracking of contribution. So it's important to note also that it is difficult to track zero-dose children using DHIS2 data, because these data are based on the current birth cohort, and by definition, these are not zero-dose children. So recommendations include alliance partners should carry out triangulation of data throughout the grant cycle, including using vaccine utilization data reported from facilities and districts to improve the quality and to verify quality of data. And the Alliance should support countries to revise vaccination data tools and systems to capture data for older children beyond the annual birth cohort. Next question, next slide, please.
Nancy, just a reminder, you're a little bit over time.
Yep. Thanks. This is my last slide, actually. So this is the advocate domain, and we have an interesting example from Nigeria that shows the utility of using knowledge translation as an advocacy tool. In Nigeria, the Learning Hub leveraged findings from subnational funding assessment to support a budget advocacy community of practice, and this included a work plan and scorecard with indicators from the accountability framework. It was tailored to state level, ensuring that advocacy was relevant, evidence-based, and impactful. And Bauchi State, in fact, created a dedicated budget line for immunization, which is an important step toward improving immunization coverage. And so the recommendation is to synthesize findings from the learning hubs and alliance partners to identify priority activities for Gavi 6.0 that can enhance subnational immunization funding, and to consider using knowledge translation for advocacy purposes. Last slide is just the Zero Dose Learning Hub website. I just want to point you in that direction, where there are numerous important zero dose resources that you can access there. And then I'll turn it over to my colleague, Dr. Yahaya, who leads the Country Learning Hub in Nigeria. Dr. Yahaya?
Yeah, thank you, Nancy. I want to share my slide. Can you stop sharing, please?
Dr. Yahaya, we will share your slides here from our side, so you don't have to worry. You just need to say next slide when you want to change. Thank you.
Okay. Thank you, Gus, and thank you, Nancy. Good morning, good afternoon, colleagues. I am going to present on behalf of the Nigeria Zero Dose Learning Hub. I'm happy to inform you of the progress and successes we have had in over 16 months of implementation. Next slide. This is a learning hub that is being implemented by Africa Health Budget Network in collaboration with the African Field Epidemiology Network as a senior partner. We are generating evidence in a systematic way to help improve how countries adapt to zero-dose reduction across Nigeria. Now, we are implementing this through a three-block pillar. The first one is on promotion of country learning under IMA. Then we have advocacy and partner engagement, then capacity building. We choose 8 LGAs, or what you will call district in other countries. And the choice was guided based on a prioritization that was done by government on which of these districts have the highest number of zero dose. And this is where we are generating our learning and also evidence. Next slide. Now, the first activity we conducted at the inception piece of our project was to conduct a scoping review of available literature. And the intention was to map and summarize existing publications that have been done on barriers and facilitators to immunization in Nigeria, and we adopted a standardized method recommended by Joanna Briggs Institute and O'Malley to arrive at this. Next slide. Now, Nigeria is traditionally divided into 6 geographical regions, from the northwest to south region. And the publications were able to pull, looking at barriers in the northwest region, we were able to find that a lot of publications have demonstrated that there is low trust in healthcare workers and poor vaccine confidence from that region. Now, most of the solutions we have found from the literature were the engagement of community influencers and especially religious and traditional leaders as vaccine advocate who really turn the tide in this region because they are heavily influential and they can convince in vaccine acceptance. Now, in the southwest region, we were able to see that they have a high demand for vaccination, but this also created another problem. The problem being that you find a long queue at these facilities And this is serving as another barrier. Some people get frustrated and they are turned back because of the long waiting time. And most of the solutions that are provided were to improve in the human resources for health in those locations. In the South, most of the studies show that there is inconvenient timing of vaccination session, and we have found studies have actually used leveraging existing communication channel and educational messaging, the social media, WhatsApp, and short messaging service can improve routine immunization coverage. Next slide. Now, another activity we conducted is a decentralized immunization monitoring, which Nancy mentioned. We are targeting the performance of immunization at the local government and also that's the district level and the sub-district level. Now, this is something we are doing as a form of responsive feedback mechanism involving all the political actors so that we inform them what is happening, looking at routine immunization coverage at the local government level, and then some priority indicators around the behavioral and social drivers to immunization. And we conducted in the cross-sectional approach, recruiting 418 eligible caregivers using multi-stage sampling across the 4 states. Currently, we have results from 3 of these 4 states. Next slide. Now, what we are able to find, we had a 0-dose prevalence of 39%, and we noted Sokoto State to have the highest prevalence of 59%. And we also noted that most of these caregivers of 0-dose children had no formal education, and they were in the poor socioeconomic status. Another finding was that 75% of these 0-dose caregivers have never attended any antenatal clinic ever, and about 54% of them deliver at home. Part of our recommendation was that improvement in antenatal visits and also delivery at facility can reduce the number of 0-dose in this location. Now, looking at the behavioral and social drivers, we're able to find out that 52%, up to 42% do not trust healthcare workers to vaccinate their children in these implementing states, and 50% of them do not actually believe that vaccines are safe. There are a lot of negative rumors around issues of vaccine safety and issues around family planning, where some of them feel that family planning agents are being used in vaccine. Next slide. Now, we found out that access was not an issue in most of these implementing areas. Looking at this map, it's a geolocation of the green dots represent fully vaccinated children or appropriately vaccinated children for age, while the red dots represent the 0-dose children where we found them in the community. And then looking at this diameter circumference, you can see the red cross is representing health facility. Now, most of these 0-dose children live within 2 to 5 kilometers of at least 2 or 3 health facilities. So access was not really an issue, but then other issues like we have shown on the behavioral and social component. Next slide. Now, the next activity we are doing is the implementation research, which is currently ongoing in 2 states, Bauchi and Sokoto, and we intend to generate evidence based on the current strategies that the government is implementing, specifically looking at the 0-dose reduction operational plan, the ZDROP, which is heavily funded by Gavi in the prioritized LGAs to improve routine immunization sessions and also the outreach session. Now, we have been able to conduct this looking at barriers and facilitators in access, uptake, and delivery. We have also assessed the effectiveness and efficiency, and also looking at incremental costs of reaching these 0-dose children. The economic study is currently under analysis, but we have some preliminary data from the gender study. Next slide. Now, we noted that females are primary caregivers in 92% of this study location, and these female caregivers have weak capacity because of their limited participation in joint household decision. Only 73, up to 73% of them were not involved. And there is a requirement for husband permission to vaccinate children. Now, at least 45% of them feel that sex of healthcare worker determine the decision to vaccinate or not vaccinate their children, and around 38% of them believe that male caregivers are ridiculed when they visit health facility to vaccinate their children. I have seen this ridiculement firsthand in some of these learning states, country learning hub states. Next slide. Now, another activity we conducted with the support of JSI and Gavi was the learning agenda for the country. We wanted to have a learning agenda specifically on zero dose that will be championed by the country and that can be implemented in most of these states. Now we look at the global learning questions, and we use a DELP approach to prioritize them and to rank them by partners, and to also map them by partners after ranking them. And we're able to bring which questions after organizing a workshop that was heavily supported by JSI to look at which of these questions are of more priority in solving the issue of zero dose. And the one that came the first was, what are the most effective approach and methods for identification of zero dose children? And the one that participant immunization stakeholder feel is of least important, what can we learn from vaccine introduction? Now, this is something we intend to continue. There will be several iterations in the next few weeks. We have mapped these questions to which partner and which stakeholder is implementing which arm. Now, coming to the last pillar, next slide. Which is on the capacity building. We have a situational analysis on the current immunization program for zero dose in the country. And we also conducted a need assessment targeting healthcare workers in this implementing state. And most of them were able to inform us that they only had been trained on two thematic areas that are relevant to immunization. And in Sokoto, we noted 87% of them, only 87% of them feel they have capacity to identify zero dose communities, meaning that we still need to train others to at least have greater than 90%, which might be seem adequate. So we are going to mount some training modules recently, and this will be inputted in the theory of change that we have developed to overall, which will lead to the overall impact of reduction of zero dose children. Next slide. Now, under the last pillar, which is on advocacy and community engagement, our partner, the Africa Health Budget Network, was able to do a stakeholder mapping, looking at individuals that are involved in zero dose reduction in Nigeria. And we have a plan for engaging stakeholders, which include government at different levels and also the non-governmental organization. Now, as part of that, we also conducted a sub-national budget analysis, and we use a quantitative and qualitative approach to do that. Next slide. Now, what we were able to see, we were able to analyze the proportion of health allocation, budget allocation to health, and then out of this health allocation, what is the proportion that is going to immunization? And we're also, because we can only infer that a component is going to immunization because some of them are being allocated to the state primary healthcare board, but there is no budget line for immunization as a whole in all of these 4 learning hub states. Now, we can see that in Sokoto has an 18% allocation in 2021, and this was just barely increased to 13.5 in 2023. Now, a figure that is not shown, whether even though this allocation has been done, but only a quarter of this funding has been released specifically in Sokoto and compared to the other 3 states. And that is why we infer that we have the highest number of 0 dose from this learning hub state. Next slide.
Now, just a friendly reminder, you are slightly over time.
Okay.
Yeah, thank you.
I will finish in the next 2 minutes. Thank you, Gus. Next slide, please. We're able to use this finding from the rapid assessment. Next slide. We're able to use these findings from the rapid assessment, from the situational analysis, from the political economic analysis that JIA has conducted to conduct at the Senate. We have also made presentations in the technical working group of routine immunization in country at the national and state level, and we have conducted continuous partner engagement, and we have presented at different academic forum in country, and we have a sort of published manuscript and also on a line which have been accepted as part of our dissemination effort. And we also conduct in-country webinar series to disseminate this learning. And there has been an establishment of community of practice in all of these 4 states for advocacy of this finding. And this is what Nancy mentioned, that a budget line specific to immunization has been created in both states. And I just got news that Kano has also done the same thing. We will continue to do this advocacy and continue this engagement. Now, last slide. Last slide. Now, we have just go back. We have been able to establish a clear link between low education, unemployment, and lower income with 0 dose, and we are recommending targeted outreach and strengthening collaboration with partners to address these context-specific issues. And we also recommend the building capacity of healthcare workers on effective communication skills, cultural sensitivity, and appropriate community engagement skills to improve service quality and reinforce trust. And with this, I come to the end of my presentation. Thank you.
Thank you very much, Dr. Yahya, Erin, Nancy, and Heidi for this comprehensive overview of the Zero Dose Learning Hub project. We do have a number of questions already in the Q&A box, and we will have 15 minutes for the discussion. After that, we'll have a quick lunch break, and we'll come back after that at 13:30. So be with us for the next 15 minutes before we break. So the first one is, Heidi, there is a question here, I think for you, specifically on ZIP, EAF overlaps in the same locations, and do you have analyses like bundling them together or separating, and with HSS, EAF, ZIP, like is that separated across your study areas?
Sorry. Yeah, no, this is an interesting question. Just want to note that there'll be a presentation later about the zero dose immunization program, the ZIP program, that I think will help enlighten some of these things. But the ZIP program is meant to operate outside the area of government control. So in theory, there should be less overlap with these HSS and EAF interventions, or excuse me, funded interventions, which are often implemented within government authorization and direct control. That said, so Mali and Nigeria do overlap in the ZIP countries. So the two learning hub countries overlap with the ZIP countries, although there are 9 ZIP countries in total. And they do also overlap in some of their focus areas and have been working as a learning hub to share findings and results. For example, in Nigeria, there was a webinar on the findings of working in conflict affected areas. And the learning hubs should be able to contribute findings in those countries related to how Gavi's Fed policy is working. And I apologize because I'm blanking on what FED stands for, but it's the conflict affected areas, the broader policy covering those areas. So I'll stop there.
Thank you, Heidi. Then there is another question related to any recommendations from the group on how countries can ensure that the learnings and the best practices and approach are integrated into programs and policy at the country level, not only at the national, but also at the subnational level. Is there any insights that you could share with the group?
Yeah, if I can go on that, Gus, thank you for that question. Part of it is what we have been doing in country, looking at the recently concluded full portfolio planning for Gavi. We were part of the subcommittees on different arms, and we have been able to push most of this recommendation through the working groups, the civil society working group, and also the service delivery. We have been able to make these findings and they have come out. Now, another issue that we do is have a representation at the state and also at the district level, being component of this technical working group or routine immunization. And one good thing in all of this assessment and surveys we did, we integrate the government and sometimes even partners in this effort. So they are aware of our findings from day one, and we conduct different level of dissemination to them locally before even coming up with them nationally. And we hope these interventions, the solutions are currently ongoing. We are going to go back for a monitoring in the next 6 months to see what are the gaps and what should be strengthened. Thank you.
And I think also like from the model, from the zero dose learning model, learning hub model as a whole, like the whole concept of embedding implementation research under a country-led learning agenda is something that can be very useful to link that, to connect, so that the learning hub is responding to the needs of the country and feeding that information in rapid learning cycles at the country level. At least this is how it has been designed to operate, and I think it's Nigeria example show it's working well in that specific context. Go ahead, Heidi.
Yeah, I was just going to add that I think there are some more good examples from the countries on how they're working to do those knowledge and those translation into policies and programs. But it is a really important aspect and very difficult, and it's part of the reason that one of the guidelines or the guidances that Erin highlighted and Nancy highlighted is a knowledge translation toolkit, which is really meant to be for use in countries to help identify your stakeholders and the type of messages and means of communication that you might want, that the Geneva Learning Foundation was a very important role in also developing this. So invite you to check that out.
There's another question here, which is an interesting one related to the fact that many zero-dose children are living within 2 kilometers of a functioning PHC facility. We saw that there is a lot of misconceptions, distrust with healthcare workers in some of their study areas. I don't think that was the case in other learning hub countries. I think the situation there is quite kind of specific. But I would connect that also with another comment made on the chat on the COVID-19 impact and increasing vaccine hesitancy. So the question here is like on how can you, sorry, where is it, the question?
Sorry, I
I think
answered
the question
it.
was answered here, sorry, but I'm coming back to it. So the question is about what strategies can be employed to address these determinants and improve vaccination coverage among zero-dose children in close proximity to health facilities. I think it goes beyond the close proximity. It's probably like the different determinants of health, and I think the BEST to some extent already brings some of that discussion. But do you know, and from the ZDLH or anyone else in the room, the types of demand side strategies that can answer to those kind of other concerns and hesitancies that we are seeing in Nigeria?
Yeah, let me just say a quick one, Gus. I think respect is reciprocal, and if we do not respect the caregivers as healthcare workers, they are unlikely going to come for the vaccination, no matter the demand we created. And it is also very important we have community dialogues around these facilities so that we can be, at least we can have some cultural sensitivity in how we approach them. I think that's one thing that can work. Thank you.
That's great, Dr. Yahaya. And I think also that we now have an opportunity with these badge tools. We now have a good opportunity to really understand the prevalence of those barriers. And I think that should be one of the objectives of implementation research, to try to really understand what works to address those barriers, to remove those concerns, and finally, like increase the impact on coverage as well in these areas. It's an opportunity that we have. I think to some extent the learning hubs will share, will bring some evidence on that, but I think more research on what's working would be needed in the coming months and years. There is
Gus,
another question.
can I jump in?
Sorry. Yes,
sorry,
please.
Gus. I just wanted to jump in and add on to what you were just saying, which I think is really important. If we could, I think getting more consistent use of tools like the BEST indicators would allow that to kind of build the evidence across other contexts in other countries on the demand side barriers. And then that only kind of gives you the buckets, the large buckets. You still need to dig in and as we were recommending, potentially using human-centered design to really understand what the root causes are of these barriers so that they could be addressed and fine-tuned in the interventions. Back to you, Gus.
Thank you. Thank you. I don't know if anyone else in the room would like to come in on that. Audrey, please.
No,
So just hold it.
Yeah.
Let me finish this and then I come back to you. Then there is a question on the operational definition of a zero-dose community, which I found interesting as a question. But I can say we don't have one at the Gavi, but do you have any reflections on that? Or the approach in the study areas, if there is any kind of a clear definition on that.
Yeah, we, just like you mentioned, Gus, it's not really a standard definition, but it's anecdotal. When you are having a cluster of children coming from a sub-district and they are zero dose, especially when we are using the decentralized immunization monitoring, we have been able to pinpoint which of the wards are causing problem in each of the local government area. And we have been able to define some as zero-dose community because of the prevalence of the zero-dose children we have. So it's not really a precise number because it depends on which area we are having. Some areas you may have 5 as the benchmark, while other areas where you have high prevalence, it can be above 5 and it can be less than that. So it is context-driven and context specific, and you can only see a tip of the iceberg as you are going on with your implementation. Thank you.
Great, thanks, Dr. Yahaya. I think we also need to kind of acknowledge there is heterogeneity in the distribution of like zero-dose DTP1 coverage. Like different communities may have different levels of coverage. Some are really kind of missed and have a very low coverage. In most of the settings, this is discussed and decided through the micro-planning process, right? There are heterogeneity at the kind of the population catchment area is like something that people, you talk to people like to the caregivers, to community leaders, to the health staff. They usually have some idea of where those kind of mixed communities are, and by defining this way, then going there and validating that with quantitative methods, this has been a very useful use of, I think, the Zero Dose Learning Hub approach. Not that we have a clear-cut definition. I think it's going to be very hard to define that because different countries have different levels of coverage as well. Having a global definition may be very hard, but I think acknowledging there is heterogeneity and that at the subnational level and even like the microplanning level, the population catchment area, there is a need to go deeper on this distribution to really identify the chronically missed communities is something that is very, very important for the Zero Dose program. I think we can move on. Audrey, you have a question, right? That you wanted to ask.
Yes, thanks, Gus. And thank you, Dr. Yahaya, for your presentation. Very interesting. And you highlighted well that maternal health services, access to maternal health services was often an issue. So like you mentioned, a low coverage of antenatal care and birthing at facilities. So first question would be, are there any efforts to further integrate to address, again, these multiple deprivations? And the other question would be, you also highlighted how low income is also another deprivation that goes with households of zero-dose children. So are there creative, and that would be a reflection maybe for all of us, but to kind of see like other potential linkages, multi-sectoral partnerships that can be done to address that. And an example I could give would be that like in India, there's a lot of social protection programs. So when going in communities with a lot of zero-dose children, then we could link up services to help households and families enroll in social protection programs that they're eligible for, and also, offer immunization catch-up services and other health services. Thank you.
Yeah, thank you. There have been approaches that have been tried in the past with some level of successes, especially the ORI strategy, which was the optimized integrated routine immunization services, which combined the nutritional services, some deworming component, and then some talks on healthcare as a component of routine immunization. Unfortunately, that has been stopped, but then there are other approaches that are coming up, but then these are really implemented in silo, and they do not really have a nationalistic tendency. But the new approach for the zero dose reduction plan, which is funded by Gavi and implemented by the National Primary Healthcare Development Agency, has a lot of promises and a lot of success because it also considers this integration we are talking about, looking at the maternal and child health and how they can be improved. Now, for the educational intervention, we have a national, unfortunately, we have similarities. Fortunately, we have similarities with India in terms of population. We are not up to the size of India, but then we also have a lot of people, and the economic condition is worsening every day. People are finding it hard to eat, and the national health coverage is really suboptimal and mainly located for government workers. But I'm aware there are some interventions like the new incentives that are doing to incentivize immunization for fully vaccinated children. This has some successes, but there are also challenges that have been noted, especially depriving, you see communities going to other catchment area to vaccinate their children instead of being localized. And this intervention is not generalized, it's just in some specific areas and contexts. I think this is an evolving issue, and it's good that we have started this conversation. And I think with time, we may have answers to most of these things. I see light at the end of the tunnel. Thank you.
Thank you, Dr. Yahya. Thank you, Erin. Thank you, Nancy. I think we are on time. There are some other questions in the Q&A, but we will ensure we will follow up with those questions later on and share that with a wider audience. Unfortunately, we are now at time